Pauline Chung. I'm the Director of Communications and Marketing for the San Mateo Area Chamber of Commerce. We're at Business Essentials this morning, and our guest speaker is Dr. John Wuchenich, and he is a private practice internal medicine and preventive medicine doctor right in our area in Woodside, soon to be Redwood City. He's board certified internist, and he's practicing the model of direct primary care. So I'm going to hand it over to John, and he's welcoming questions during his presentation, and we will send out a recording and the slides at the conclusion. Thank you for joining us today. There you go, John.
Great, thank you so much. Well, Pauline, you've done a wonderful job introducing me. Let me just pull up the notes I have for myself to share with the group while I talk. I wanted to take some time and go through some stuff. So let me just tell you a little bit about myself here first. So like you said, I'm Dr. John Wuchenich. I'm an internal medicine physician. I'm new to San Mateo here in this past year, so I don't know all of you all that well yet, but I am a California native. I was born in the beautiful, though now mostly burned out, town of Paradise, and then grew up in Southern California. I attended medical school at Loma Linda University, and from there went to Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire, where I did my residency in internal medicine, and then stayed a few more years and did a leadership preventive medicine fellowship as well, and got a degree in, or a master's in public health from the Dartmouth Institute for health policy and clinical practice along the way. From there, I followed my fiance, who's now my wife, to Seattle and then Pittsburgh, Pennsylvania, where I worked at major medical centers for a couple of years while she completed her training. And so now we're back to California to be close to family. My wife is a pediatric anesthesiologist at Lucille Packard Children's Hospital in Palo Alto. And like you said, I opened up my direct primary care practice here in San Mateo. If you guys don't know what direct primary care is, I usually describe it as blue collar concierge medicine, but it's kind of its own little topic. So we can talk about that later if you guys are interested. As a disclaimer, I will talk on a variety of topics, and we'll try to use specific examples for some of these things, but I'm not here to endorse any individual test or company, and I don't have financial ties to any of them. So this is all just general information and shouldn't be taken necessarily as personalized medical advice. So COVID really has made a mess of things, right? But is it safe just yet? Can I wait? How long can I push this off? So what I want to do is shed some light onto how we smartly answer those questions, how healthcare can tailor answering to those individuals looking for personal risk characteristics and behaviors, and the different options for performing some of the important tasks in this now socially distanced world. This is not terribly sexy stuff. It's kind of the eyes glazing over levels of boring here. But it's the same kind of boring that prevents planes from crashing and buildings from collapsing. It's the kind of maintenance stuff that keeps things from going off the rails. So the first thing to talk about is that much of this is screening. It does not apply for people with known medical problems who need their periodic checkups for management of those conditions. We're talking about screening, we're talking about prevention. So an easy place to start for all of this, excuse me one second, is the United States Preventive Services Task Force. They have a website that you can go to, and if you just plug in your information, you can see what the recommended screening is for people. So just to pretend, I'll be a 55-year-old woman, here are a few other things. And if I put this information in,
that's pretty much
show me recommended activities. So this is a bit of a crude tool, but it's a nice starting off point for people, because I have some who come in very enthusiastically and say, here are all the things I need to do. And I say, okay, interesting, but let's talk about which one of these are going to be actually very relevant. Sorry, was someone trying to jump in here?
I just said that's pretty much me right there.
So when we come to these things, if we were to look at this list of recommended activities, most of them fall into a few different buckets. So I was going to use this as a framework to talk about what these preventive tasks are. Any one of these things is a lecture in and of itself. And indeed, when you go to medical conferences, they are. But to cover some ground, let's stick to sort of the big picture and not get bogged down in the details. So I'll spend most of our time talking about cancer screening because that's where I get most of the questions about. So the purpose of screening is to find disease before it causes symptoms so that you can treat it early and reduce the disability and death that it might otherwise cause. There are a few important things to talk about when it comes to cancer screening because screening isn't perfect. Number one, screening doesn't find all cancers. Some cancers evade the detection of our tests. Others grow so rapidly that even with our normal intervals of screening, we won't catch them. Secondly, screening finds some cancers that will never become a problem. And this is what is referred to as overdiagnosis. For instance, some breast cancers that we find on mammography will never turn into the kind of breast cancer that will lead to disability and death. And we can't tell necessarily which is which. So the medical community's worked hard to better differentiate which are which, but we're not there yet. And so this overdiagnosis phenomenon leads to additional testing and to treatments. And for some people that provides no benefit, and worse yet, it still causes the physical, emotional, and financial harm. And finally, when we're using these population studies to guide our individual decision-making, we don't always end up with personally satisfying results. The benefits of screening are seen over a population, and even then unevenly so. What happens is we overestimate the benefits, ignore some of the pitfalls, and don't necessarily end up with a personal satisfaction in the whole process. So let me give an example of that. If you're an average risk 50-year-old person going for colon cancer screening, we have to screen probably 1,500 to 3,000 people to prevent one death from colon cancer along the way. So that means your chances that this test helps you is less than 0.05%. And if you look at that number and say, wow, that is small, why am I even bothering doing this? I don't really disagree. If you're going to ask me what's the risk of pushing it off a year, I can tell by the numbers that that risk is very small. And that's because colon cancer is a great thing to screen for. It grows slowly, and that's the exact quality that allows us to catch a cancer like this early and make screening worthwhile. If you're 65 years old, that number needed to screen drops by a factor of 4 to 5, somewhere in that range. So to prevent one death by screening, we only need to screen a few hundred people to catch something that's going to be different. And so maybe those odds are now good enough to change your mind and say, this is worthwhile now. So that's why I like some of the decision aids. It helps put these things into perspective. And as we look at these individual cancers in the next few minutes, I've listed some of the ones that I find particularly helpful. So let's start with colon cancer screening. Usually this starts at age 45 or 50, depending on which guidelines you're looking at. We have a lot of different options for screening. Colon cancer tends to be slow growing, and that's why we have such long intervals between tests. So if you ever have had a colonoscopy and they say come back in 10 years and you can get your next one, that's why. Most cancers start out as these small little polyps and then grow over time before they turn cancerous. I've listed a few of the different types of colon cancer screening tests here that we use, and I'm a fan of colonoscopy itself because of its sensitivity. So I'm not here to wanting you to look at and understand all the different parts of this graph. But if you look at that one on the far left, that's the colonoscopy screening, and we're looking at sensitivity there. And so what that's saying is 95% or 19 and 20 times the colonoscopy will detect cancer if it's there. That's what sensitivity means. It's the value that shows how accurately a test finds a patient with disease. But one of the things I've started doing a lot more during the pandemic is using this FIT DNA test. So that's the one on the far right. And you can see the sensitivity is almost just as good. You might have seen this advertised on TV even in the last few years as Cologuard. I think it was approved by the FDA in 2014. It's also very sensitive. And so it's a fecal immunochemical test which basically looks for parts of blood in the stool. And it combines that with a test for looking at altered DNA sequences that are associated with colon cancers. And so I really like it because there's no prep, there's no sedation. You collect a stool sample at home, you mail it in, and you have results back in the next 2 weeks. So anyone who's been reluctant to go into the gastroenterologist's office, I say, here, we have an alternative. The recommended time for doing this is once every 3 years. And we can always change our minds as things settle out. So I think it's a really legitimate alternative. Mammography remains the mainstay of breast cancer screening. If you've seen a word like tomosynthesis, it's like mammography. It's an X-ray as well, but it takes multiple pictures. So you get more of a 3D reconstruction of the breast. I will say breast cancer screening in low-risk women is fairly controversial. The large meta-analyses we have about all-cause mortality really don't show compelling evidence that screening saves lives for low-risk women. And it's kind of the poster child for overdiagnosis and overtreatment. I think it's really important to have good risk stratification for women when it comes to breast cancer screening, because screening is very valuable in higher risk women. Understanding what that risk looks like helps us choose what the right screening strategy is. There are a few different calculators out there. The one I have listed here is really nice because it shows graphically what the benefits and the harms are for the different strategies. So if you've never been to one of these websites, I'd recommend going, checking it out, plugging in some numbers, seeing what it's going to be for you now, see what it would be in 10 years, or find out what it would be for your cousin or your friends. Because some of these shared decision-making tools have gone a long way in helping patients understand what those things look like. Lung cancer screening is really only helpful for people who have smoked for a number of years. That's the only ones that are recommended to get this. Similar to breast cancer, there are some nice decision aids out there. This one is out of the University of Michigan, and I use it all the time. Screening is done by CT scan, and there's not really an alternative. Lung cancer tends to be fairly aggressive. And so even for my nervous patients, if they're ones who should be getting screening for lung cancer, I have advised that they don't put it off during these times. Cervical cancer is actually quite a different story. Similar to colon cancer, it grows slowly and is preceded by precursor and early stage cancers, making it very treatable if caught early on. There is a lot of nuance when it comes to when to start screening, when to stop screening, how often should you screen, what kind of screening test should you get. And I tell people, it's the best to talk to your OBGYN about this and let them help you make a smart decision as to what we're doing for your schedule. We don't have at-home testing yet, but looking at it, they're trying to develop some tools to help with this sort of thing. Those are the main cancers that we screen for. Does anyone have any questions on those before we jump to a different topic? I know I've been going very fast.
There's a question in the chat from Cheryl. Should people who smoke marijuana get screened for lung cancer?
That you won't see that as part of the recommendations. In general, people who use marijuana smoke at very different rates in terms of the amount of smoke that they're exposed to, and probably don't need to end up in the same risk categories as those who smoke cigarettes. I mean, for people who smoke cigarettes, doing a pack a day, 20 cigarettes a day or more is very common. And yeah, you never see people who use marijuana using it at those sorts of levels.
Yeah, I just received a message from a very good friend that her mother was in extreme pain, went to the ER. This is just about a week ago, and then they found out that she had lung cancer and that it had spread to other organs. So she basically went into hospice at the hospital, and she's already passed away. So within a week, this happened. So the whole family's in total shock because they never knew she had lung cancer.
And that's one of the hard things about lung cancer. And one of the reasons it's so hard to screen for is it's often very aggressive and very fast growing.
Wow.
And it's hard to catch something when it's small enough to do something, but still big enough that you can see it. So those limits of detection make it a hard thing to screen for. All right, well then let's keep going. I'm going to talk about some of the chronic diseases next. Heart disease is the #1 killer in this country, and that's full stop, period. We worry a lot about cancer. I just spent some time talking about it. Many of you have heard the statistic, right? Breast cancer affects 1 in 8 women in their lifetime. And that sounds terrifying, and it is, it's important, but women are 10 times more likely to die from heart disease than from breast cancer. So when we think about how do we prevent heart disease, what we do is we go after the risk factors. And that's why we screen for diabetes, and that's why we screen for cholesterols, and that's why we check blood pressure. And these things are getting easier and easier to do at home. You can buy home test kits for cholesterol and diabetes. They're fairly accurate. They're a little more expensive than going to the lab. And probably the cholesterol discussion should move past your good cholesterol, bad cholesterol, HDL, LDL stuff. And we're talking more about ApoA and ApoB and some of the other lipoproteins. But nevertheless, we're getting more of this testing out of the lab and into the home. So you can walk into Walgreens or CVS and buy these home testing kits over the counter, or even order them online. You can get a home blood pressure cuff. They're very accurate. I have a number of patients who come in, and as they look to see me in the office, they say, my blood pressure is never this high, but I get nervous coming into the office here. And so I often have them check their blood pressures at home. And sometimes I'll even get more accurate readings there. My advice to patients regarding screening for these things really varies. For people who've had these tests before, you kind of have a sense for if they're doing well, if they're normal, if they're sort of on the borderline, or if they're heading to problems. And usually they can tell me how things have been. So the ones who in the last 6 months have gained 15 pounds, I'm going to counsel them a little bit differently than the ones who say for the first time in their lives now they're exercising every day, they're finally cooking at home and eating right. And if they've never been screened before, then that's when you start to get into their family history and some of the other risk factors. So that gives me a lot of information. Who someone is will really help determine how aggressive do we need to be with keeping on top of some of the screening stuff. I have patients who I will test every 3 months, and I'll have patients who I test every 5 years because they're different individuals. The same thing goes with other forms of testing. So there's some risk calculators out there for osteoporosis. They help me decide how much I might even have a need for someone to get a DEXA scan. It doesn't change my reminders to them, though, that they should be getting enough calcium and vitamin D, or making sure they get some strength and weight training on a regular basis. The rule is large muscle groups that cross the hip and the spine twice a week. And so we also do some screening for other diseases as well, transmissible diseases. Again, you have risk characteristics that tell you probably who should be keeping on top of these things a little more than not. And if you look at the USPSTF recommendations, they're not quite so nuanced when they just say, well, everyone should be screened for hepatitis at some point in their life. Okay, but is right now the time for that? Who you are as a person really helps us decide. Okay, immunizations. I'm trained in preventive medicine, and I recommend vaccines for everyone. I'm probably least enthusiastic of all of these about flu shots in healthy adults. I think the evidence is very strong that it can be helpful in children and older individuals, but for healthy young and middle-aged adults, it really depends on how well the vaccine is matched to the strain that year. And some years it's pretty good, and other years it's more or less worthless. What is coming down the line is a universal influenza vaccine. It's in phase 3 clinical trials right now, looking at effectiveness. And so we're hoping we may have that in the next few years, and that'll be nice because no longer then will it be an annual thing, but you might get it. And I don't think we know quite yet what the frequency will be, but it's going to be a longer lasting influenza vaccine. Vaccines you can get about at just any pharmacy. I tell them if you need them, just go get them now. There's no reason to put those things off. Shingles, I think, starts usually at age 50, and pneumonia at 65. And there's plenty of places to go see where you can get vaccines. That's what that vaccinefinder.org is. And there's even flu shots where you don't need appointments or anything around here. You don't need identification, you don't need insurance, and you can, so it's really for anyone these days.
So what do you consider older adult? What age?
Well, it's not so much necessarily an age.
Oh.
I think by the time my dad just turned 70. And so I think for him, I'd be saying that's a number that for me would stay. For most people, I would say probably by this point, you should be having it. There are recommendations for others as to, maybe some might put that line at 65. A lot of it's going to be, again, sort of who the person is and such. You'd think that someone who's gotten a flu shot may be less likely to transmit than the flu to someone else, but the studies that we have on these sorts of things really haven't borne that out. So even if you get the flu shot, you may get a mild version of the flu. You may be asymptomatic. You may think you have avoided it, and yet you're still able to pass it along. So I'm not sure that the immunity is transferable there. So I would say I recommend it, but I don't think I believe strongly that the science says that this is universally beneficial. So I'm not so forceful in that recommendation. Finally, we look at behavioral things. During COVID, I've seen a number of people make some really positive changes, and I've seen some others make some really negative ones. I like a periodic check-in with my patients just to be a safe place to step back and reflect and be honest about patterns of behavior. For acknowledging positives, I think it's really good to encourage people when they're doing well, and then also have some accountability for the negatives, because especially alcohol use right now has been a real struggle for a number of my patients. And at the same time, I've seen some, do really well in losing 10, 15 pounds. So setting aside a space to talk about those things is just a good habit to get into on some sort of periodic basis. As a doctor, I take it upon myself to do that for many of my patients. And the pandemic really hasn't slowed down our ability to address these things. Telemedicine makes all this really convenient, and actually makes it even more accessible for me to engage with patients regularly. And so I can do some of that cognitive behavioral therapy myself, because it's not nearly as hard if someone doesn't have to come into the office, if I can just check in with them even 10, 15 minutes, a week or every other week. So I know this was really fast. This is the 50,000 foot view of things, and I will share the slides, but I want to make sure if you guys have questions on things, we have a chance to talk about what those might be.